I'm one of the surgeons at Southpaws. Today we have this, it's going to be a pretty challenging case, which is a dog that has a large recurrent soft tissue sarcoma of the interscapular space. It had been operated on previously by another vet and then came to us, and I didn't realize how deep it went the first time. So I tried electrochemotherapy, and that was about 4 months ago, and now the tumor has not recurred within the skin, but it's definitely come back in the muscle. So it has recurred all over the place, over the dorsal scapula and the thoracic spine, and that kind of thing. And so we're doing a wide local excision. If you haven't already done so, please subscribe to our channel and turn on notifications so you'll get a ding on your phone the next time we live stream. So I have tumor here. I have tumor here along the old incision line. And maybe, yeah, so we're just going to have to do quite a wide excision. And this looks a lot like what we would see with an injection site sarcoma in a cat. It looks almost exactly like an injection site sarcoma in a cat. So luckily I don't need to get the 5 centimeter margins that I would in a cat, or I don't think there'd be a lot of dog left over. So we are just starting our skin incision here. And keeping tension on the skin as you cut is really, really helpful. It just makes kind of the tissue layers just sort of fall apart. And I'm taking advantage of the fact that these wound edges are going to contract. Getting a bit light. So dog's reacting a little bit. Now over here, I think is going to be the microchip. So it's always, again, a battle. Luckily, to keep them anesthetized, but not to have their blood pressure tank. Gelpies, please. Big ones. Bigger.
The biggest is number 4. There is 2 sterilized, number 5 is.
Yeah. Can't remember where I was. So I think that the microchip is right there. I can palpate that. We'll take our Sen retractors, please. So I'm just being really careful not to allow this to penetrate into the tumor. And these big sarcomas are kind of my thing. And the thing with these is just being confident that in going for the margins that you need, or not trying at all, otherwise you're going to leave cancer behind. Still waking up. So that's microchip right there, I just saw it. Come on in here, Lucas. All right, so I'm not going to have to touch the other scapula, but the ipsilateral scapula, I am going to have to remove a portion of it. And we've got tumor going all the way across midline here. Can I get cautery turned up to 40 and 40, please? Well, let's get our sends in here.
40, 40.
Just carefully retract on that, please, Lucas. So I'm up to the other scapula there. That's rhomboideus there. And cutting through, and we're going to have to use lots of post-op analgesia on this guy. And these are just the epaxial muscles up here. All right, so feel the scapula there. All right, so let's release that, please, Lucas. It's always a bit of a puzzle just figuring out how I can go circumferentially around this thing. Just got a bleeder in here. Hold on to that, please. So now I'm going to come around the front, so we'll take that out. So this is a grade 2 soft tissue sarcoma, previously removed by the primary care vet, I think about a year ago. Oh, actually not. No, I did electric chemotherapy on it more recently than that. So, and so there's our microchip there. I'm just palpating, so that's spinous process there. So now let's get a send going up that way, and a send coming back this way. So now we're also trying to excise. I don't know if you guys can see this. The old incision is right there. Thanks for that. Vanna? Vanna? Do you know who Vanna White is?
I've heard the name, to be honest. I don't know.
So
exactly
she's
who it is.
from Wheel of Fortune,
Yeah,
and
right.
she was the person who pointed
She
out the letters.
Pointed things out.
Yeah.
That's what I'd assumed it was a reference to, but someone who pointed at things.
Yeah. Okay. All right, so now we're just going to have to lift that up here. Grab a hold of that maybe with a sponge, or a lap sponge, yeah, and then I'll just provide some counter retraction down here. You just have to be really careful not to cut too deep so that we're not cutting into tumor. So if we breach the tumor pseudocapsule, we're in trouble. What vessel is that? What vessel did I just cut? If I'm asking you, it must be important.
Yeah. Lateral thoracic?
Close. So I'm asking because there's an axial pattern flap that's associated with it.
Yeah.
And that axial...
That's the omocervical one there.
No, that's cranial.
Thoracodorsal?
Yes.
Yeah.
Cauteries, ligature's not working. Can we have a look at the screen? Can you move over, please, Lucas? Invalid instrument. So we're probably going to have to get a new ligature tip. Did it work before?
This?
Yeah, I can't remember if
Last
it...
time we used this one.
Okay. So that is very definitely the thoracodorsal artery, which is important because we use it for an axial pattern flap. So coming around here, we'll be getting closer
Third time lucky there.
to the scapula. What's that, on the guess? Yeah. Sorry to put you on the spot.
That's all right.
All right, so then I'm going to come up. There. And obviously we're going to create a big hole here. But luckily, we've got lots of spare skin. So that's the spine of the scapula right there.
Yeah, right.
So it's like, I love cancer surgery because you have to have a really good appreciation of the 3D anatomy. Does that one seem to be working now?
It's plugged in.
Does it say invalid instrument? That's fine. That's all good? Yeah?
That was because I grabbed air.
Yeah.
Yeah, right. Just going to attach this in, shall
Yeah, thank you. All right, so let's get another look at where we are. So that's shoulder blade, scapula right there.
Try and step over that and be on the left side of it, that'd be good. Yeah, nice.
Let's get that on the somewhere so it's not going to fall. All right, so these are my spinous processes here, which I am going to have to take some, but I think I'm going to try to lift the scapula off first.
Yeah, right.
So come around front here. Just make sure, yep, that feels clear. Retract that cranially, please. We can get a Gelpy in there if you like. Make sure my head's not in the way. Again, with cancer surgery, basically we draw a line around the tumor where we want to cut and just make sure that we never compromise that margin. So I drew my line before surgery, or visualized my line before surgery based on the CT scan. Which one is it?
Yeah, that's the one.
And just know that I cannot compromise that margin. You can just drop that. All right, so we'll lift up on here. So that's trapezius there. That is a vessel that we often encounter when we're doing amputations. I think that's going to be hard to ligature because it's in the... no, this one will be. Say that it's in the bone. Okay, so I have to make the decision as to whether I'm going to sacrifice a bit of the scapula or not. And this is an old little dog. We're still in the field? No. All right, so... what we might do is just zoom out a bit. Problem is, if we zoom out, it just gets more washed out. I'm down on the scapula here. Where's our bleeding? All right, so what I'm going to do is I'm going to cut the spine of the scapula off. So let's just grab onto that.
Such to saw blade, please.
Sorry, to saw blade.
Thank you.
What size do we want?
Medium.
Medium, I have
Can you give us a look at one? Show us one.
this one.
Yes.
It looks good.
Yes. So that's scapula right there. I don't know if you guys can see that. That's scapula sitting right there. Just going to grab my Freyer elevator, scrape a little bit of bone off here. Okay, so I've just done a partial scapulectomy. And we're just going to elevate that bone. Okay. Just grab onto the scapula there, so hold on to that. Do we have that little bone cutter as well? Bigger? Yep, that's the one. Yep. All right. So a little residual here. Okay. This is so much like an injection site sarcoma in a cat. Okay. So now we are down to the spinous processes here. And this is one of the most common locations for injection site sarcomas in cats. Are we still in the field yet? So basically what I'm doing now is I'm just exposing the lateral aspect of the spinous process right in here. And then I'm just going to come and take the top off of those with my bone cutters. Pause for a minute to administer some pain relief. Cautery. Had my brain on pain relief and I was doing cautery. So basically, if I'm going to do a cancer surgery, I'm going to cure the patient, or I'm not going to go to surgery at all. So that's always my objective, is to cure the patient. So if you go in half-hearted, not only the patient still suffers the pain of recovery, and you still don't get a clean margin, and so the tumor comes back. Let's see what we've got here. Okay, so that's our tumor sample. We can definitely not see any evidence of any cancer in our surgical surface, so I'm very happy with that. Can we get some mepivacaine, please? So now I'm just going to go and clean up our bleeders. The biggest allowable dose.
You
I
want
think
a
it's,
wound catheter for this one, Charles?
yes.
As
So 4 milligrams per kilogram, please.
well?
And then we'll get a wound soaker as well. All right, I think we've got plenty of skin to close. Yeah, that'll be easy. And so I don't use xylazine atropine commonly. We are more likely to use ketamine as an adjuvant to like a methadone ACE pre-med. We use metidomidine also commonly, which is a little bit more limited in its side effects. So I'm just injecting mepivacaine into all of the cut surfaces of muscle. So I believe that that's probably what's most painful. Can I get some 2O PDS, please? And we'll get, do we have a wound soaker catheter? Wound soaker catheter. Ask Thierry about it. Yep. There's a question about if I can leave this running to the end. The problem is that I often leave the surgery early, and some of my assistants don't like to leave the video running while I'm gone. So that's why I usually stop the video when I'm finishing with my part. What was that?
Oh, I didn't hear what you said.
It's camera shy.
So this is a catheter that's going to infuse mepivacaine into the wound.
This is up to there.
Okay, great. So,
Charles, do you want the species?
sure, thank you. All right, so let's get our right angle forceps. And just grab a blade. Can I please have some 3O nylon? Just put that in like that so it doesn't bend the end of the catheter over.
You can do a trap here if you like.
Yeah, that'd be great. Okay, Lucas, can you please retract on that?
I'll give you these as well, mate. So we have some easy to cut them.
And just run that suture for me, please.
These are the ones that are made by Mila, so we don't need to do a trap. We've just got these nice things in there.
So what Thomas said was that this wound soaker is made by Mila or Mila, And they're really cleverly engineered so we don't have to do finger snares with them. Just be careful, Thomas, that it doesn't kink the catheter over as it goes through the skin. Often I'll leave the video running if I have one of my residents who's happy to live stream, but I don't want to leave the surgical interns hanging on their own.
No scissors, please, mate. What's that? Can you cut something for me? Yeah, of course.
And interestingly, there often aren't a lot of muscle layers that we can really close here because we've created such a defect.
Rotation is better like that, isn't it? Rotation is better than I much prefer the orientation if we can. So it's just easier to work with.
Yep. And I might just try to do a little loop of suture around the catheter just to try to keep it semi where we want it. Yep. All right, so I've got latissimus dorsi. Yeah, great. So latissimus dorsi, I might be able to pull that up. Can I get some more 2 OPDS, please?
Is that going to be able to slip out through the end of there, do you think?
It should come.
Yeah, sorry. So I shouldn't have asked.
Can you lift that? Can you pull that forward for me, please? Thank you. Better it gets stuck now than...
Yeah, it's true.
Yeah.
It's a question about, do you like wound-soaked catheters for amputations? I think that we do, don't we?
I have not used a lot of wound soaker catheters, but we've just gotten, they weren't available until fairly recently in Australia, and we used to kind of fashion some out of a urinary catheter, but we are using them more and more, and basically any opportunity that we have to put a soaker in, we're better off.
I think we're in the UK, Charles, when they've had them for a while, they use them all the time for amps, because just like here where we've cut loads of muscle bellies,
yeah,
they're really nice for it.
Yeah. And sodium channel blocker analgesia is so much more effective than systemic opiate analgesia by just a million miles, and so we use it whenever we can. We use some kind of direct local block. Okay.
There's a question earlier about the scratch pad. Just pause, I think.
Oh, right. Yeah.
So we've got a little scratch pad here, which is basically just a piece of sandpaper. And it comes in our kit, which is handy. Yeah.
Just trying to orient myself, sorry. So that's dorsal, caudal, cranial, correct?
Yeah. And just make sure that when we ink that, we don't get any ink down between fascial layers, so I don't want it to look like it was dirty when it wasn't.
That's the last thing we want.
Yeah, because then you'd be talking about adjuvant therapy and stuff that's unnecessary.
Yeah.
So let's see what we've got here. So we're going to have some dog ears. I don't think there's any choice in the matter. Can I get some more 2OPDS, please? And I don't think that there's a justification or a reason to put in a closed suction drain in this. I just think it's unnecessary.
Someone wants to know how long you leave the soaker in.
You can leave the soaker in for a couple of days, as long as you want, 3 days probably. Thomas, what was your experience with that in the UK?
Yeah, I think, just as you said, it massively depends how the patient's doing.
And usually we're trying...
It tends to be around sort of 48 hours or so.
Yeah,
24 to 48 hours.
and usually we're trying to get the patient home, and so we're not going to send it home with a wound soaker in, so that's kind of the limiting factor.
Often, sometimes, I think they work so well that you can actually get more opiates in general soon after surgery.
Yeah.
Depending on the surgery itself, which is pretty cool.
Yeah. Thomas, I will have you start. Can we get another 2OPDS, please?
We'll do subcut on this side.
Probably, yeah, subcut if you can. And cut those off for me, please.
On our left here, that'd be great. In terms of how this is coming together, Charles, what are you thinking? Okay.
Just like that?
Like that? Yeah.
Just going to release. No, that's... Just getting underneath here, Thomas. So I'm just doing mostly, Thomas, inverted, kind of buried sutures.
Sometimes they don't have the best cutting ability right at the end of the scissors.
Thank you. And then I'll have you do some simple, either cruciates in the scan or something like that, yeah. And then in the areas where we're under a bit more tension,
Yeah.
put some more robust cruciate sutures in.
Yeah. Okay, mine, please, Charles. Thank you.
Try not to go through the skin here. Cindy, can you scroll down on the screen there and just see if there are any questions that we haven't answered? What is the? So that rasp is just a piece of sandpaper, basically, that we use to clean the cautery tip. And I've already read that one. Seen that one already. Yeah, so we have cut several muscles. We've cut the epaxial muscles along the spine, spinous processes. We've cut the rhomboideus, the trapezius on the ipsilateral side, latissimus dorsi on the ipsilateral side, supraspinatus, infraspinatus on the ipsilateral side. Contralateral side, just the epaxial muscles, and I think maybe the latissimus. The scar cranial to the tumor is where they attempted to remove this previously.
Which we have excised.
Yeah, which we have gone and removed that scar, because that whole scar, if we've had recurrence, that whole scar is contaminated.
We've got a new question. Are we expecting lameness post-op?
Uh,
No issue?
So we'll have some soreness. I don't think we'll have a major issue with lameness. May have a bit of lameness for a few days afterward from cutting that latissimus dorsi. That would be the main one. Putting in a cruciate suture right at the intersection there.
It's going to be some dog ears here, but that's all right.
Yeah, can't be helped. Yep,
Sorry, sorry, just 1 second.
and that's a skin suture. So.
Just have those two short, please.
So as far as post-op care on this guy, it's just going to be lots of pain relief. He wasn't on any meds beforehand, so we'll probably keep him on a fentanyl plus or minus ketamine CRI overnight.
Have one more 2 PDS, please.
Did you hear that, Thomas?
Sorry, would you mind repeating that?
So fentanyl and then plus or minus ketamine CRI
Yeah,
overnight.
sounds good.
And then just see, and this dog is insured. I don't think we have any pressure to send it home.
Yeah, definitely. stay in order tomorrow.
Yeah, and see how it's doing tomorrow. Both, please. Sorry. And this dog will definitely not be on antibiotics post-operatively. There's no reason.
Can you have a hand, please, Emily, if you wouldn't mind? Cutting that one, and then just standing on my right, and then just creating a bit of tension there for me on that bit flap.
And I'm very fortunate. I recognize having somebody scrubbed in with me on all of these cases that makes the closure so much quicker.
Sorry.
Can I get another 2O PDS, please? Okay.
So Luke, we're asking you to have your hands up.
It's okay.
Sorry.
All right. I almost got you.
Yeah.
I had a professor, a surgeon, when I was a resident that didn't particularly like me in the first place. And I did a total ear canal ablation, and that was back in the day when we put drains in them. And I inadvertently sutured the drain in, and then went away for the weekend, and he was on Saturday morning, went to pull the drain out on Saturday morning, and the drain wouldn't come out. And he had to go in on a Saturday morning and reoperate on the dog to cut the drain out. And he was not happy.
Good way to make friends.
Yeah. I did nothing to advance my cause as far as him liking me.
I have actually a very, very similar story to that with the first stitch-up that I was allowed to do at RBC in my rotating internship. Just tacked the pen rows down during the closure.
Yeah.
Someone else had to come fix it.
At least it wasn't that, the department head who didn't like me in the first place.
Yeah.
Live and learn.
Yeah.
Grow a sense of humor.
Where have you done some cuts up to?
Yeah. And I have a doctor's appointment at 6:30, so I'm going to have to leave no later than 6. Do you know who's on call tonight?
No, I don't know.
Yeah. Again, we've had 2 residency-trained anesthesiologists join our practice full-time now, which is just such a treat to have this level of care for our patients for analgesia and managing tricky anesthetics and stuff like that. And the best thing is that they're really, really nice guys. And so it just is such a, it's such a joy working with them. And they're so compatible and happy to work with you. And just are there to really make our jobs easier, which is really lovely. I can't think of a lot of private practices that would have 2 anesthesiologists. I'm sure there are a few in Australia, but not many. Okay. All right, so I'm just going to put in a couple of more big cruciates here at my junction.
Yeah, okay, that's it. Okay, great. Yeah.
And all Thomas is going to do now is just some cruciate sutures in the skin. So I am going to go ahead and finish up the live stream.
Thank you.
If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. We'll go ahead and wrap it up. So let's see. So this closure is not an amputation. We've taken a big interscapular mass off a dog. And so this is just primary closure after that. So anyway, thanks a lot for watching, and we will